Welcome back. This is Dr. David Preston narrating Fundoscopy Knowledge in Neurology Part 2. In Part 1, we talked about the anatomy and physiology of the optic fundus, how to use our ophthalmoscope, and some normal aspects of the normal fundus. In this Part 2, we'll review the normal fundus, and then we'll go on to look at abnormalities that every neurology resident needs to understand. So let's look again at the normal fundus. I'm going to turn on my laser pointer here. So here we have the optic disc. All of this is the retina. Here are the blood vessels. When we look at the disc, we look at the contour of the disc. It tends to be an oval-shaped structure. It tends to be orange or pinkish. It tends to be well demarcated. In the center is the optic cup, where the blood vessels come from. If we look at the ratio of the cup to the entire disc, normal tends to be about 0.3, up to 0.5 may be considered normal. From the optic cup comes the blood vessels, the arteries, and the veins. You'll recall the arteries are smaller, the veins are larger, the veins are redder because they have deoxygenated blood coming back. Then we have the retinal areas, and in the center we have our macula and the fovea, the area of central vision where most of the cones are located. So here is our normal optic disc, which we'll refer to when looking at several abnormalities. Now, of the abnormalities that a neurology resident must recognize, the most important by far is papilledema. Indeed, this is the ACGME milestone that's required of all neurology residents, the ability to recognize papilledema on fundoscopy. What is papilledema? It's swelling of the optic disc, but specifically caused by increased intracranial pressure. Why does that happen? The optic nerve sheaths are continuous with the subarachnoid space of the brain. Thus, increased pressure is transmitted directly to the optic nerves. So papilledema is not a disease itself, but rather it's a manifestation of an underlying disorder which results in increased intracranial pressure. Now, a patient who has increased intracranial pressure often has headache, of course. However, the papilledema itself really does not cause any symptoms. It is true that the patient will have enlargement of the physiologic blind spot if you do very careful visual field testing. But from a practical point of view, patients have no symptoms from the papilledema, especially when it is early or mild. There's a difference when someone has had papilledema for a long time or it's very severe. In those type of cases, there may be blurring of vision or visual obscurations. Papilledema left unchecked can cause death of the nerve fiber layer and can result in visual loss itself. So for instance, in patients who have pseudotumor cerebri, papilledema untreated can actually result in visual loss. But for most patients who present with papilledema, they're not going to have much in the way of any visual symptoms. Now, what do we find on fundoscopy? We see congestion of the retinal veins and we lose the venous pulsations. The disc becomes hyperemic and it fills the cup, so we don't see the cup very well. Of course, the major finding is that the disc edges are blurred. Very importantly, this happens first in the upper and lower margins and in the nasal margin. Very importantly, the temporal margin is spared until later. Another very important finding on fundoscopy is elevation of the nerve head. This really marks it as papilledema. This took me a long time to figure out, but we're going to show you an easy way to figure this out in just a moment. As papilledema gets worsened and the disc becomes more blurred, we actually lose the vessels. They'll appear to disappear as they course near the disc. And then late in papilledema, we can sometimes see hemorrhages. Now, papilledema is often graded on a scale of 0 to 5, this Friesen scale. 0 is normal. So scales of 1 to 5, which we'll see examples of in a moment. Basically, most importantly on grade 1, which is minimal, we have a C-shaped halo of swelling around the disc. We'll see that C-shaped pattern in just a moment. In score number 2, there is a circumferential halo and then elevation of the disc. In grade 3, there is obscuration of some blood vessels that leave the disc. In grade 4, there's total obscuration of the disc. And in grade 5, we lose all the blood vessels. So let's look at early papilledema. This is stage 1. So let's get out our laser pointer again. So our laser pointer here, so here's our retina, here's obviously the disc. Now when we look at the disc, can we see the disc margin? And actually on the temporal side, we can see it fairly well. But on the superior and inferior and the nasal portion, the disc is blurred. So let's show an example. This is the kind of the inverted or reverse C-shaped blurring of the optic disc. This is what happens first. Now, when we go back and look at this, we also want to figure out, is the disc elevated? And the easiest way is to look at the blood vessels, because when the disc is elevated, you will see the blood vessels leave the disc. They will then run down the hill to the retina. So let's do an example of this. Right here, look at the blood vessel here as it runs down. The one next door, same story, comes up, goes down, then it's straight. Over here, comes over, down the hill, then it's straight. Over here, comes down, then it's straight. So the disc head here is elevated. So the blurring and the elevation of the disc really marks this as papilledema. This is an early stage. Let's go on to stage 2. In this case, now there is blurring of the entire disc in a complete circumferential pattern. So when we look here, around 360 degrees, the disc is completely blurred. Is it elevated? Yes, it is. Here's the blood vessel that comes out, then it goes down the hill. Over here, it goes over the disc and then down. Over here and then down. So this would be grade 2 papilledema. This is getting a little bit more easy to recognize. Now, what happens in grade 3? Now the disc is really choked. So now we see complete obscuration of the disc border. We can see the disc is elevated. Look at this blood vessel here. It goes straight down, then it goes over. Again, it goes straight down, then it goes over. So the disc is elevated. But now there's a new finding, and that is that some of the vessels, we lose them. They appear to disappear as they leave the disc. This marks this as stage 3. In stage 4, there is a loss of the major blood vessels on the discs themselves. So now we don't really even make out the disc. It's all completely blurred. Again, here you see this blood vessel going down and then straight. We are losing almost all of our blood vessels on the disc itself. And then finally on grade 5, it's the same as grade 4, except now there's partial or more commonly total obscuration of all the blood vessels on the disc and as they leave the disc. So here you cannot make out any blood vessels very well. You have to get pretty far out here before you start to see the blood vessels. It's completely blurred. So this is obviously very severe papilledema. Now, let's talk about the difference of papilledema, papillitis, and retrobulbar neuritis, because these are actually very similar, but they're also important. So papilledema, what is papilledema? We just talked about it. It's swelling of the optic nerve, which is caused by increased intracranial pressure. However, the fundoscopy of papilledema is basically almost identical to that of papillitis. What is papillitis? It's inflammation or infarction of the optic nerve head itself. As opposed to, say, optic neuritis, which can be papillitis, or optic neuritis, which can be retrobulbar optic neuritis. And in this case, it's inflammation or infarction of the optic nerve itself. So these are similar, but they're also very different. So disc swelling occurs in papilledema, but it also occurs in papillitis. However, if someone has optic neuritis, which is retrobulbar, the disc will look completely normal. When someone has papilledema, almost always it's bilateral. There's some rare exceptions. However, when someone has infarction or inflammation due to vasculitis or some type of autoimmune condition, it's usually unilateral for papillitis and retrobulbar optic neuritis. As far as pain with eye movement, it's unusual for papilledema, but it's very common in papillitis and retrobulbar neuritis. But here's the big one, and that's visual loss. As we talked about, patients who have papilledema have no visual loss. Yes, when you examine them, they'll have an enlarged blind spot. However, a patient who has optic neuritis, if the optic neuritis is of the optic nerve head, that's papillitis, you'll have marked visual loss. The patient will have a central scotoma to complete blindness, and this will be the same if it's retrobulbar neuritis. You'll have a marked loss of vision, a central scotoma to complete blindness. If you check your pupil reaction, papilledema, it's normal, but for papillitis, which is optic neuritis of the nerve head, or retrobulbar optic neuritis, you will have an abnormal pupillary reflex. If it's very mild, you'll just have an afferent pupillary defect. The disc elevation, we talked a moment ago, is very important in papilledema. It's usually marked. But be careful, in papillitis, you can actually have some mild disc elevation. Of course, you won't see that in optic neuritis, which is retrobulbar. As far as hemorrhages, they can be present in papilledema, they can be present in papillitis, but they will not be present in retrobulbar optic neuritis. Venous pulsations are always going to be absent in papilledema, where they may be present in papillitis or optic neuritis. So the bottom line is the patient who has optic neuritis, which is due to inflammation or infarction of the optic nerve, the fundoscopy will look fairly normal, but the patient will have marked visual loss and will have an abnormal pupillary reaction. A patient who has papilledema or papillitis, they will look very similar on fundoscopy. Papillitis tends to be unilateral, where the papilledema is bilateral. However, in both of them, the disc will be swollen, the disc can be elevated, there can be hemorrhages. But the big difference is, in papilledema, there's really no visual symptoms, where in papillitis, there are marked visual symptoms. This is a very important concept. So let's move on to our next important finding, which is optic disc cupping. So the optic cup, it's the white center area, white cup-like area in the center of the optic disc. This is where the blood vessels emanate from. There's a normal cup to disc ratio, which is the ratio of measuring the width of the optic cup divided by the width of the entire disc. You can think of this as measuring the donut hole compared to the whole donut. In a normal individual, that cup to disc ratio is usually around 0.3. Up to maybe 0.5 in some situations might be considered normal. However, a cup to disc ratio more than 0.5 is abnormal. It can be seen in several pathologies, but most importantly, and the one you should know, is it can be seen in glaucoma. And why is glaucoma important? Because it is the most common cause of preventable visual loss. So let's look at a normal optic nerve and a normal optic cup. So here is our optic disc, and if we measure the distance here, and here's our optic cup, and if we measure the distance here, and we figure out the ratio, in this particular case the ratio is 0.3. This is a completely normal cup to disc ratio. Let's contrast it to another case. This is a case where there's some optic disc cupping, and the cup to disc ratio is enlarged. So again, think about the entire width of the disc and now the width of the cup. It's much bigger. Indeed, when you measure this, this is 0.5. This would be very concerning that the patient has glaucoma. Let's look at another one which is even more marked. This is much more marked optic disc cupping. So again, here's our optic cup, which is very large, our optic disc, which now has a very narrow border here, and actually this ratio is 0.8. Nice example. You can see that this disc margin is not blurred at all. You can make out the arteries very nicely. You can make out the veins very nicely. Here's the central retinal vein right here, but we have a very much enlarged cup to disc ratio. Here's a last one to look at where the cup to disc ratio is 0.7. So again, we see the disc margin very, very well. The optic nerve is not elevated. We can see the central retinal vein here, the central retinal artery, but this cup to disc ratio is too large. This is what we expect to see in glaucoma, a very important finding to recognize. Now, the next finding is optic atrophy. Optic atrophy refers to the death of the retinal ganglion cell axons. On fundoscopy, the entire disc will look pale, moon-like appearance. It really is an end-stage phenomena that occurs from numerous causes of optic nerve damage, any place in the retina all the way back to the lateral geniculate. This can be optic neuropathies which are toxic, optic neuropathies which are compressive, that occur from trauma, those that occur from inflammation like sarcoidosis or multiple sclerosis. You can see this from chronic papilledema, among many other causes. So let's look at the first case here of optic atrophy, and you can see the disc is very, very pale. Very, very pale. We're not seeing a good demarcation between the optic cup and the optic disc. In addition, in some of these cases, it can be somewhat difficult to differentiate this from an increased cup to disc ratio. But in this case, the entire optic disc is just pale and ill-defined. Let's look at another example. Here's another example of optic atrophy. It looks like the moon. And I think you can agree it looks like the moon. You can actually see your central retinal vein quite well right here. But again, we don't really make out, we can't really make out the cup to where the cup starts and the disc starts as well. So this is optic atrophy, which is a late stage phenomena. Say you had optic neuritis and it was very bad and you made a poor recovery, you could have a disc that looks like this in the end. Here's another case of optic atrophy. Again, the optic nerve just looks like a pale moon. We really cannot make out the nerve fiber layer very well at all. Now, the next major thing to talk about is retinal hemorrhages. There's different types of retinal hemorrhages and they're associated with different conditions. So the ones that we care about the most are really the first three. The dot hemorrhage, or known as dot and blot. This most often occurs in diabetes, sometimes occurs in hypertension. This occurs from rupture of deep capillaries. Then there's the flame hemorrhage. This is rupture of superficial precapillary arterioles, or small veins. It can occur in many situations, but most classically in systemic hypertension. Then there are boat hemorrhages. These are ruptures of large superficial retinal veins that occur into the space between the retina and the vitreous. Sometimes these bleeds will actually break away and will break into the vitreous cavity itself. The boat hemorrhages are most commonly associated with intracranial pressure, especially abrupt increase in intracranial pressure, and where this most likely happens is trauma, but especially subarachnoid hemorrhage from a ruptured aneurysm. And then lastly, you can have hemorrhages in your macula, you can have hemorrhages in your vitreous, but most often this is something that we would leave to an ophthalmologist. So let's look at some examples. This is an extremely abnormal retina, but the small dot here, this is your so-called dot or dot and blot hemorrhage, the type of thing that you often see with diabetes. Small capillaries are leaking. Now, let's contrast this to a flame-shaped hemorrhage over here, which is a more superficial precapillary arteriole. This most classically happens in hypertension, but there's often an overlap between hypertension and diabetes. Then lastly, we have these boat-type hemorrhages, which are quite large, and often you can imagine the hemorrhage was taking up this full space, and you almost develop this fluid level. Boat-shaped hemorrhages most classically occur with a sudden change of intracranial pressure, especially when an aneurysm bursts. So let's look at a very dramatic boat hemorrhage. And this is a very dramatic boat hemorrhage. Boat hemorrhages are also known as subhyaloid hemorrhages. They occur between the posterior hyaloid membrane, which is part of the vitreous membrane, which separates the rear of the vitreous from the retina. This occurs secondary to a sudden rise and increase in intracranial pressure. It's thought to force blood from the subarachnoid space directly into the pre-retinal space, or it dramatically decreases venous return, leading to stasis and then vessel rupture. So if you ever had a patient who had the abrupt onset of a severe headache, and you looked into their retina and you saw this gigantic boat hemorrhage or subhyaloid hemorrhage, this would be almost pathognomonic for rupture of an aneurysm and an abrupt change in intracranial pressure. Very, very important. Now, can you sometimes have hemorrhages that occur in the macula? And this is what a macular hemorrhage would look like. If this happens, obviously there's going to be dramatic loss of vision because the macula is where we have central vision. And then if we have hemorrhage that goes into the vitreous, we're really unable to see through to the retina at all, and all we see is blood, which is basically obscuring our retina. Let's go on to the next finding, which are cotton wool spots. These are fluffy white patches which occur in the retina. They're a result of accumulation of axoplasmic material within the optic nerve fibers from reduced axonal transport, but most importantly, they're felt to be secondary to ischemia. That is, they're really microinfarcts of the retina. So classically, they're seen in diabetes and hypertension, cotton wool spots. So let's look at an example. Here's an example. So here's this white spot. This is a retinal infarct that occurred in a patient with hypertension, a cotton wool spot. Here's another one where the patient has many cotton wool spots. So again, these are all retinal infarcts, these kind of fluffy white spots on the retina. Pretty easy to recognize. Now, the next finding we don't see very often, but it's really important in neurology, and this is the Hollenhorst plaque, named after Dr. Robert Hollenhorst, who first described it. What it actually is, it's a cholesterol embolus in a blood vessel, usually an arteriole, within the retina, and it appears bright yellow. Almost always this occurs from cholesterol plaques, which then break up from the internal carotid artery, travel down the internal carotid, into the ophthalmic, into the central retinal artery, and then lodge often at a bifurcation. They're quite refractile. So let's look at a blow-up of a Hollenhorst plaque. So here we can see our retinal vein very well. If you were just looking in, we said, gee, if you want to find the disc, don't forget, when you see this V-shaped pattern, the V, the point always points towards the disc. So this is the way we would look towards the disc. So this will be a vein, this will be an artery, and we see this highly refractile abnormality right here. This is our Hollenhorst plaque. This is very important finding in a patient who has a suspected TIA. Sometimes these plaques can be very, very small. Let's look at the next one. We have a picture here of the retina, and again, you can make out the artery very well here, so we know this is the direction to the disc. Here's the vein, but you can see this quite refractile abnormality right here. This is a Hollenhorst plaque. Now let's move on to our next abnormality, which is a central retinal artery occlusion. So this is basically a stroke of the eye. Your central retinal artery is obviously very, very important. So when this happens, you develop a very pale fundus with a cherry red spot in the macula. The macula is a relatively transparent structure, and it develops a red appearance from the underlying choroid vasculature, which is not supplied by the central artery. This finding usually shows up several hours after the blockage of the central retinal artery. When you block your central retinal artery, you develop a severe, sudden, usually painless loss of vision. When this happens, it's usually from an embolus, but you can see this as a result of vasculitis, especially giant cell arteritis. So let's look at an example. This is our central retinal artery occlusion. If you were to look at this just superficially, you'd say, well, things look pretty good, but you'll notice the retina is very pale, And now the macula, you see this central cherry red spot. Here's another example of central retinal artery occlusion. Again, the retina is very pale, but where the macula is, you see this cherry red spot. This is a finding that we expect to see when someone has a stroke of the eye of the central retinal artery. Now, if you contrast that to a central retinal vein occlusion, this is very dramatic. So when you block the vein, the central vein, you get a backup of all the venous pressure. This results in hemorrhages, very dilated veins, a lot of edema of the retina, of the macula, edema of the optic disc, cotton wool spots. You can have different amounts of visual loss. Usually it's painless. This is often differentiated into non-ischemic and ischemic central retinal vein occlusion. In the non-ischemic, often this is a milder form with slight visual loss and may have a good outcome, as opposed to an ischemic central retinal venous occlusion, which results in severe visual loss and often a poor outcome. So let's take a look at one of these. So the first thing you notice is the entire fundus is extremely abnormal. We can probably guess that the optic disc is someplace over here, completely obliterated by swelling. And what are we seeing? We're seeing these dot and blot hemorrhages. We're seeing these flame-shaped hemorrhages. We're seeing cotton wool spots, and to get a complete obscuration of the optic disc. Here's another central retinal vein occlusion, and again, you can just see blood everywhere. If you look at the veins, you'll note they are really dilated here. The veins up here are really dilated. We do not see the optic disc very well at all. Here's another very dramatic example of central retinal vein occlusion. Again, we can probably guess that the optic nerve is someplace in here. It's totally obliterated. We're seeing all these superficial hemorrhages everywhere from venous back pressure. So this is our central retinal vein occlusion, a fairly easy thing to recognize on fundoscopy. Now, if we look at hypertensive retinopathy, this can result in focal or generalized arterial narrowing. One of the most classic things we'll see is AV nicking, or arterial venous nicking, that when an arteriole crosses a venule, it results in compression of the vein with bulging on either side of the crossing. The arteries are often quite small. They're often described as copper wire or silver wire. They might be somewhat refractile. We'll often see cotton wool spots, which again are basically infarcts of the retina, as well as hemorrhages and other exudates. So here's an example of hypertensive retinopathy. So let's just look at this for a second. First, we noted that the disc here is certainly blurred on the superior margin, inferior margin, as well as the nasal margin. It's clearly better on the temporal margin. We can see that the disc head is elevated. Here's the vein running down then out. Here's a vein running down and out, so the disc head is actually elevated. We can see our dot and blot hemorrhages here. We can see a flame-shaped hemorrhage here. We can see a cotton wool spot here, more cotton wool spots. So this is the typical finding we might see in hypertensive retinopathy. And again, the findings in hypertensive retinopathy and diabetic retinopathy are very similar. Not a surprise when you think about lacunar strokes in the brain caused by hypertension and diabetes. The pathology is very similar. We talked a moment ago about AV nicking, arterial venous nicking. Here's a blow up. Again, we recognize this as the arteriole. Here's the venule. The venule, of course, is darker red. It's larger. And here is the compression of the vein in the AV nicking, something that's quite commonly seen in hypertensive changes of our retina. Now, we're probably all familiar with the fact that diabetes is a major cause of retinopathy, and there's non-proliferative and proliferative diabetic neuropathy. The non-proliferative is the first stage of diabetic neuropathy. we'll see microaneurysms and narrowing of blood vessels. Hard exudates and macular edema are typical findings, and early in the course, vision is not usually affected. So here's an example of some microaneurysms. So let's look at the disc here. And superficially, the disc looks pretty good. It looks pretty sharp. We can see the veins. We can see the arteries. The retina looks pretty good. We know the macula is going to be down here. It looks pretty good. Now, if we look very closely, though, we see these two little dots. These are microaneurysms, one of the hallmarks of early non-proliferative diabetic retinopathy. You might say, well, how do we tell this from a hemorrhage? It's pretty close. The hemorrhages tend to be a little bit bigger, a little bit less well-defined. Now here's a case of much more well-developed diabetic retinopathy. And you'll probably say to yourself, gee, this is pretty similar to that of the hypertensive retinopathy, and indeed, it's almost identical. So we see our flame-shaped hemorrhage here, flame-shaped hemorrhage here. Here's a dot and blot hemorrhage, a lot of cotton wool spots over here, over here, over here, which are a sign of retinal infarcts. And if you look very closely, you may see a few little dots, maybe over here, which is probably a microaneurysm. But again, a tremendous amount of overlap between diabetic retinopathy and hypertensive retinopathy. And of course, there are many, many patients who have both. Now, later in the course, the diabetic retinopathy becomes proliferative, and in this situation, it's an advanced stage, and it's marked by neovascularization, which means there's formation of new blood vessels. We still have cotton wool spots, we still have hemorrhages, but these new blood vessels are very serious because they're quite fragile and they can easily break, and when they do, they bleed. So here's an example of proliferative diabetic neuropathy. And if we look at the optic disc, it's pretty sharp. We can see the vein quite well here. We can see the artery quite well here. But look closely, you see all these new blood vessels here. This happens later in the case of diabetes. Here's an example where it's really, really marked, where we have marked neovascularization. We can see our dot and blot hemorrhage, dot and blot hemorrhages. So in this stage, these blood vessels are very easy to break, cause hemorrhage, and then visual loss. Now, getting near the end here, I want to talk about optic nerve drusen. Drusen are globules of mucoproteins or mucopolysaccharides that calcify in the optic disc. They're felt to be possibly remnants of axonal transport of degenerated retinal ganglion cells. But most importantly, they're an incidental finding. But why we bring them up is that they can be confused with papilledema. The optic disc will develop a lumpy type appearance, and it's important not to mistake optic nerve drusen as papilledema. So here's an example of optic nerve drusen. Now the disc here is really blown up, and you might say, well, gee, it's not so sharp over here. It's not so sharp over here. It's obviously a lot better over here on the temporal, so you might be tempted to say, well, this is probably early papilledema. But when you look closely, you see this kind of like glob, this lumpy appearance, this lumpy appearance, this lumpy appearance. This is optic nerve drusen. This is a benign finding. It does not represent papilledema. Let's look at another example. Here's another example of optic nerve drusen. And again, you have this kind of lumpy shape around the optic disc. And finally, let's look at a really good example of this where you really can make out these calcified lumps around the disc. You do not want to mistake this as papilledema. Again, this is typically a benign finding. We defer to the ophthalmologist about can this cause any type of visual problem, which it rarely does. But this is optic nerve drusen. So this ends Fundoscopy Knowledge in Neurology Part 2. Feel free to watch this as many times as needed. The most important finding by far is papilledema, which we want you to be able to recognize, followed by an increased cup-to-disc ratio, and then know the major pathologies of hemorrhage, of cotton wool spots, of what a central retinal artery occlusion looks like, what a central retinal vein occlusion looks like, and what you expect to see in diabetes. Thank you again for listening.